I was wrong when I said that GR was the last. I knew that Meghan Lyman is kind of going to wrap this up with her talk on Canada. I just wanted to see if she was awake and maybe get her blood pressure going up a little bit. Anyway, Meghan, really looking forward to this because I think you've got maybe the broadest view perhaps of these complications in a contemporaneous fashion. So we're looking forward to your comments on COVID-associated candidiasis. And with that, and Meghan is works in the mycology branch at CDC along with Tom, and has been a great partner in all this. Thank you, Meghan.
You're muted, Meghan.
Can you hear me now?
Yes.
All right, perfect. All right.
Perfect.
I guess I was falling asleep. So thanks for having me to talk about the impact that we've seen of COVID-19 on Candida. So I'm going to be talking about Candidemia and Candida auris. So thanks to everyone for sticking around to the end, and I'll try and keep it on the high points. So first, I'm going to start off with Candidemia. So in addition to co-infections of COVID-19 and aspergillosis or mucormycosis, there have been an increasing number of reports about co-infections with COVID-19 and Candidemia. But these have been had limited sample size and geographic scope, and all just include one, maybe two hospitals, and maybe have just a handful of cases. So we thought this was a great opportunity for us to investigate how Candidemia may have been impacted using CDC's Candidemia surveillance through the Emerging Infections Program, which is an active population-based surveillance system of culture-confirmed Candida found in blood specimens among sites in 10 states, which you can see are pictured here. So last summer, we added questions to collect information related to COVID. So I'll describe a bit of our findings, which were published several months ago. And at the time of this analysis, there were information about 251 Candidemia cases from 8 surveillance sites, and 25% of those had tested positive for COVID-19 in the 30 days prior to Candidemia. Many of the underlying conditions were more common among those without COVID, including conditions commonly associated with Candidemia like malignancy or liver disease, while other conditions like diabetes or obesity, which are risk factors for severe COVID-19, were perhaps not surprisingly more common among those with COVID. But we are very interested in healthcare risk factors. Most cases with COVID-19 were healthcare onset, while a greater proportion of cases without COVID were community onset or healthcare associated community onset. And related to this, cases with COVID-19 in blue were being diagnosed with Candidemia longer after admission, while cases without COVID-19 in red were diagnosed sooner after admission. And looking at specific healthcare exposures, prior surgery and prior hospitalization were more common among those without COVID, while cases with COVID were more likely to have more high acuity healthcare exposures like ICU admission, mechanical ventilation, renal replacement, and central lines. And looking at immunosuppressive medications, systemic corticosteroids were twice as common in patients with COVID and were used for COVID treatment in more than 80% of those cases. And the IL-6 inhibitor, tocilizumab, was also more common in COVID patients and only used in those cases for COVID treatment. We found that Candidemia cases with COVID-19 had worse outcomes. They were more likely to end up in the ICU. They had longer hospital stays and had double the case fatality. So overall, we found that patients with COVID-19 who developed candidemia were less likely to have typical underlying conditions and instead had more acute exposures related to their COVID-19 management. They really seemed much healthier until becoming acutely ill because of COVID-19. But our analysis was based on a convenient sample of cases available at the time, and we're looking forward to finalizing data for all the cases to evaluate changes in overall incidence. So next, I'm going to talk about the impact on Candida auris. And as you can see, there's been a lot of media attention on Candida auris during the pandemic, and I'll talk a little bit about what we've seen and both the direct and indirect impact of COVID on the spread. Tom mentioned all of these challenges for Candida auris surveillance earlier, but I did want to focus on the last one, the decrease in screening, because screening is so important to identify individuals who are asymptomatically colonized with Candida auris, but can still shed it into their environment and spread it to others. And here's a graph showing the volume of colonization screening conducted by CDC's antibiotic resistance lab network. And you can see there was a dramatic dip in screening around the start of the pandemic. The volume of screening has been increasing since then, especially after we saw evidence of transmission in some new geographic areas that prompted widespread screening. And despite this rise, there are still areas with a high burden of auris that have also been heavily impacted by COVID, where the amount of screening is still far below the pre-pandemic rates. And because of these challenges with screening, we've been encouraging species identification of all Candida specimens from any body sites to pick up as many cases as possible just through clinical specimens. And the number of cases of Candida auris has been steadily increasing since it was first reported in the US in 2016. And you can see this is true for both clinical and screening cases. And clinical cases are ones where the specimen was collected as part of routine clinical care, not necessarily invasive specimens. And screening cases are ones where auris was detected through colonization screening by swabbing the skin. And many of the earliest cases were introduced from abroad, but the majority of cases now are the result of local transmission. And you can see there was a slight dip in cases at the beginning of the pandemic. Again, this was likely related to decreased screening when the entire healthcare system was strained and preoccupied with COVID. So it really does mimic the trends you saw earlier in screening volume. But the number of clinical and screening cases has subsequently increased to levels higher than we've ever seen, and often in new areas. But even in areas that had controlled transmission of Candida auris, we've observed outbreaks, including in hospitals where we have not typically seen as much transmission compared to long-term care facilities like nursing homes. Many of these outbreaks were on COVID units and were likely related to changes in routine infection control practices, like using PPE conservation strategies. But even this is likely still an underestimate because of the challenges I mentioned in surveillance and decreased screening. And another sign that there's more undetected cases in transmission is that we're seeing cases without links to known cases or healthcare abroad. One example of a large outbreak on a COVID unit of a hospital that had previously had cases without experiencing much transmission. Half of the patients screened on this unit were positive, some of which later had clinical specimens that were positive. And on investigation, healthcare workers on this unit were wearing multiple layers of gowns and gloves and using the base layer for multiple patients. So they had many opportunities to contaminate this base layer and then spread auris across the ward. And the healthcare workers were understandably afraid of becoming infected from COVID and were trying to use extra PPE to protect themselves, but may not have realized the risks associated with these different practices that they were implementing. You can also see that the geographic spread and number of states with cases has increased over time. And this is a map showing cases over the past year. I guess it's ends in May, but you can see that the most affected areas are currently New York, New Jersey, Illinois, California, and Florida more recently. But you can see that it started to creep into nearby states as patients move around and cross state lines. And this map is at the state level, but not all parts of each state are equally affected. Sometimes there are pockets of auris in certain areas of the state, but it can obviously easily spread to new areas within that state or nearby states. We've also seen increased resistance. Before 2020, there were only 4 cases of pan-resistant auris reported in the US. And these 4 cases had no epilinks to each other, and they all developed a echinocandin resistance on treatment, likely related to antifungal pressure. Additional testing didn't detect resistance among any healthcare contacts that were screened or environmental samples to suggest that this type of resistant strain was being spread. And there was some thought that resistance may be associated with a fitness cost that was maybe preventing it from spreading so easily. But we recently identified 2 independent clusters of pan-resistant or echinocandin-resistant cases among patients at the same facility who had not had prior echinocandin use. And this was the first evidence suggesting that this type of resistance might be spread. And these findings really highlighted the importance of susceptibility testing to identify resistance, especially in patients needing treatment for clinical infections or those not responding to treatment. And obviously these infections are really concerning because they're resistant to the first-line treatment echinocandins, considering the high level of fluconazole resistance or azole resistance. And, you know, for many of these that are resistant to all 3 classes, treatment options are extremely limited. And through visits to facilities there during the pandemic, we identified some common gaps in key infection control practices that may contribute to spread of auris. Some of these practices were related to COVID, and others might have just reflected poor baseline practices. So for hand hygiene, we found that many facilities were not aware that alcohol-based hand sanitizer was preferred over soap and water, in addition to missed opportunities for hand hygiene and limited access to supplies like hand sanitizer. For transmission-based precautions and use of PPE, facilities, as I mentioned, were inappropriately using double gowns and gloves that increased self-contamination. They were also reusing gowns and not changing PPE between patients, especially those in the same room. So after observing that gap and hearing that facilities were using conservation strategies, even when supplies like PPE were available, CDC changed their guidance to encourage facilities to use conventional and contingent strategies when possible, and only use crisis strategies when absolutely necessary. We also found that cohorting practices often were only focused on COVID and ignored other multi-drug resistant organisms, or were really complicated and resulted in frequent and unnecessary patient movement and more frequent exposures for other patients. And there have continued to be gaps in communication of Candida auris status and other MDRO status between facilities and health departments, which is really important to prevent spread and allow appropriate containment measures and infection control precautions. And environmental cleaning and disinfection is so important because Candida auris is shed into the healthcare environment and can persist for a very long time. But we observed inadequate preparation of bleach, insufficient cleaning of high-touch surfaces, and mobile medical equipment. And many common healthcare disinfectants are not effective against Candida auris, especially products with only quaternary ammonium compounds. but EPA just established a list of products tested and approved for Candida auris called List P. And the good news is that all List P disinfectants are also effective against COVID. But if List P products are not available, List K products are still should be effective against C. auris as well. So we have lots of information on our website and updates about Candida and Candida auris. So I will end there, and thank you.